Choudhary, who's come all the way from Mumbai.
Good morning, everyone. A short and small paper from Mumbai, and my colleagues Patinkar, Harley Luther, and Shasham Joshi are not here. But before I start, the work that we have done, I couldn't have done it and couldn't have presented it without their input. This is the place where we work in Mumbai. It's a large corporate hospital, semi-private, for 1,500 beds, started in 2010. And I've been associated with them for almost 4 years now. The eloquent area tumours. The word itself, eloquent, is controversial. Some of my neurology colleagues say that every part of brain is eloquent. So what I meant here by eloquent is those where surgeries are likely to give lasting neurological deficits. And of course, spinal cord, all of it is eloquent because the deficits it can cause. So surgical resections, we all know the options. I'm not going to go from them, right from biopsy until some of our American colleagues are firmly believe in gross total resections. So we've had 533 patients over a period of almost 4 years now, and selected 22 patients, 16 cranial and 6 spinal. And these are the patients who have had surgery. The tumors are located either in eloquent areas of brain or spinal cord, intrinsic, and had peri-operative deficits, but went on to make very good, if not complete, near complete functional recovery at 12 weeks. And these are the patients that we've isolated, audited, and I'm just presenting what do we think the reasons for their good recovery was. The parameters I've just studied were age, grade of tumor, and extent of resection. I think the first two are probably not surprising, and I'll dwell more on the extent of resection and what we did. Our patients were relatively young. Maximum age was 65 years, and I'll show you the patient, and minimum age 5 years, and I'll show you that patient as well. And average age was 23 years. Grade of the tumor, again not surprising. 20 patients who recovered had grade 1 to 3, while 2 patients had grade 4 tumors. Both of them I'm going to show because it is so unlikely that after radical surgery, patients have full deficits and then they recover in glioblastomas. Among extent of resection, we have been very aggressive as far as surgical approach is concerned. 21 of our patients who had recovered had gross total resection of tumor. 1 patient had subtotal resection. Some of the nuances that we follow, all of us in the team, we do not administer any specific anti-edema measures except head elevation. We do not use peri-operative steroids or diuretics. We do not use intraoperative mannitol. This is how our tumors look because they haven't had any pre-operative anti-edema measures. The brain is swollen and the tumor is almost coming out after the dura is exposed. We use only pre-operative 1 dose of Flupasef as antibiotic coverage, and we use only peri-operative anti-epileptic coverage unless the patient has had seizures before. We do not administer hypotensive anesthesia. Some of the surgical steps, we pay meticulous attention to venous drainage. We prefer peripheral dissection to internal decompression. We identify the arterial supply early in the dissection, and the excision of the gyrus is the aim rather than the decompression of the tumor. We do not use brain retractors in any of the surgeries, and we prefer in toto excision of just the cortical regions. The end point of our tumor surgery is gross macroscopic resection as proven by post-operative imaging. Few examples. This is a 26-year-old man with mild left hemiparesis with an intrinsic brain tumor occupying the motor area. That's how when the tumor is exposed, the tumor is circumferentially dissected and not internally decompressed. The gyrus is in fact isolated from surrounding gyri through microscopic circle dissection. And this is how after the gyral excision the cavity appears. The brain becomes lax, no need for mannitol or steroids even post-operative. This is the post-op CT scan. Another lady with a large tumor occupying, playing the Sylvian fissure, occupying the deeper parts of frontal and temporal lobe. In the middle one, you can actually see the middle cerebral artery coursing over it as well. Big flap, Sylvian fissure, temporal and frontal areas exposed. All the superficial middle cerebral veins meticulously preserved using microscope. And in fact, you can see the middle cerebral artery as well identified and dissected. This is after excision of the tumor. Pre-operative scan, post-operative scan, and in the last, you can see the middle cerebral artery preserved. Another tumor with a grade 2-3 astrocytoma. Straight incision using neuronavigation, gyrus identified, circle dissection, tumor exposed, tumor excised, gyrus bearing, the tumor excised, and the veins surrounding it preserved. Deep-seated tumor, grade 3 astrocytoma with a cystic component, post-operative scan. Spinal tumor, again ependymoma, post-operative scan. This is how the tumor is exposed, removed in toto. Metastasis, again in the motor area, gross total excision of the tumor. Spinal ependymoma, another case, tumor exposed, after tumor exposed. This is something that I said I have 2 cases of glioblastoma. This is one of them. This is a recurrent tumor. Initially it was grade 1, operated 5 years ago. In a young 26-year-old man, the tumor recurred. We felt it was coming from the posterior part of midbrain and pons, the follicular area, occupying the pinal region and supracellular region as well. We went through Stein's supracellular approach, and that is the post-op scan. The tumor is gone. It appears as if we removed a part of follicular, but actually we haven't. The tumor had compressed it completely. This is the patient who was quite obtunded, complete ophthalmoplegia and complete ptosis, immediate post-op. This is 2 weeks later, just before he went home. He still has partial ptosis and some ophthalmoparesis, but it is improving. He is able to stand and walk with support. Glioblastoma, now I will radiotherapy. Another, there was a child with a 5-year-old presented with an obtunded condition after a few seizures. And a large tumor, probably a grade 1 astrocytoma, located deep in the left side. That's a post-op scan. Again, we are very radical for all the patients that we decide to operate on. And this is the patient who was left hemiplegic, right hemiplegic, but now is able to walk after 3 weeks surgery. The report came as grade 1 astrocytoma. The scan was satisfactory. No further treatment is contemplated. Another patient with a glioblastoma, large tumor in the right parieto-occipital region. This was the first one, was the youngest member of the team. This was the oldest member, he was 65 years old. Again, there was, you can see there is subependymal enhancement indicating the tumor had already spread to the ventricular wall, and even the gross total resection of this case without any lasting deficit was going to be difficult. As the immediate post-op scan within 24 hours of surgery, and this is the patient 1 week ago. We see that what he's saying in the local dialect that he's 65 but after surgery. He's saying that I feel as if I'm 50 years now, although I'm 65. This is 15 months after surgery and radiotherapy. So some of the unfavorable indicators for surgery were older age, high-grade tumors, multiple metastasis, fixed preoperative deficits, incomplete removal of tumors, deficits caused by venous insults and arterial infarcts during surgery, flaccid weakness lasting for over a week, and optic nerve dysfunction and visual field deficits, I felt, are unlike if we had this, even after radical surgery or optimum surgical management, they were unlikely to improve. So in conclusion, from our observation of 22 patients in a cohort of 533 patients over the last 4 years. We believe that younger age, a lower grade of the tumor, and radical resection of the tumor appear to be favorable factors in potential recovery of the peri-operative neurological deficits in cranial as well as spinal intensive tumors. I thank you very much for your patient listening, and thank you SBNS for inviting me.
Thank you very much. Should have time for one question.
Yeah. I understand what you were set to gain by not debulking some of those larger intrinsic tumors that you showed by going around them.
Actually, we did debulk them, but we did carry out peripheral dissection first, got the vessels identified, got the normal brain out of the way, and then debulk using CUSA. I simply didn't have enough time to do that. So I'm not saying that we took them out like convexity meningiomas. No, that wasn't the impression I meant to do. What I meant was peripheral dissection was carried out first, followed by internal decompression, followed by radical excision.
Any other comments? Yeah.
I'm just wondering, do you think your reluctance to use anti-edema medication or one sort of other techniques contributes to defining the actual tumour cerebral interface to a greater extent?
Actually, yes, I do believe that. Because once we have, I showed a couple of cases where the brain is swollen, our natural tendency is to have as much relaxation as possible. But if the tumor is cortical, then as soon as you divide the arachnoid over the sulci, then the tumor under pressure almost delivers itself. All you have to do is use patties and suppress and develop the plane, and your half the work is done by the edema itself. And as soon as the tumor is removed, the brain is nice and lax, and none of these people require postoperative anti-edema measures. But that's only true for some of the cortical and juxtacortical regions, not for deep-seated tumors.
Thank you very much.
Next speaker, Mr. Ahmed from Aberdeen Royal Infirmary, Intrathecal Matter.